Hello and welcome to the next episode of the Psychedelic Medicine Podcast. I'm Dr. Lynn Marie Morsky, your guide on this journey. And this week, we're going to be discussing how to know if psilocybin is safe for you with Dr. Seth Mehr. After a 20-year career as an emergency medicine physician, Seth founded Cascade Psychedelic Medicine in 2021, treating clients with depression, anxiety, and PTSD with psychedelic ketamine therapy. He also serves as the Health and Safety Director and a state licensed psilocybin facilitator at the Intertrek Service Center in Portland, Oregon. Now, before we get to Seth, just a reminder that the Psychedelic Medicine Podcast is for educational and informational purposes only. Nothing here is to be construed as medical or legal advice. And as always, if you are a clinician, like Dr. Mehr, and you would like to learn more about how psychedelics may impact your patients, please check out the Psychedelic Medicine Association. It is our mission to get you up to speed on all things psychedelic, including indications, contraindications, medication interactions, all the things your patients may come asking questions about. If you'd like to learn more, please check us out at psychedelicmedicineassociation.org. Now, without further ado, thanks so much for joining us today, Seth.
Thanks, Lynn Marie. So glad to be here with you.
I'm extra stoked because Dr. Mehr is a member of the Psychedelic Medicine Association and has been for many years, and Cascade Psychedelic Medicine is one of our sponsors. So thank you, Seth, for your dedication to the PMA over the years. And the reason I'm having this discussion here with Seth today is that he is one of the authors of a course that the Psychedelic Medicine Association has put out on managing medical risk for patients seeking psilocybin therapy. Now, I know we had a discussion, if you were with us back in 2024, I believe, with Dr. Reed Robson on a similar topic. But Dr. Mehr and I were just at the Psychedelic Science Conference in Denver and did a talk on how not to just decide, okay, this is not a yes or no as to whether psilocybin may be safe for you. He has a number of ways to mitigate the risk and make a safety plan. And so, Seth, I'm so excited to have you on here to discuss this with us. If we could start off by having you lay out some categories of risk that patients may find themselves in that may lead them to examine further what may be involved in creating their own safety plan.
Yeah, happy to. Thank you, Lynn Marie. So, as far as risk categories, I think about this in three different scenarios. One is medical conditions, two is medication interactions, and three is mental health. So, for example, medical conditions would be cardiac conditions like coronary artery disease, arrhythmias, um, poorly controlled hypertension, aneurysms, long QT syndrome, perhaps a family history of early sudden cardiac death, neurologic issues like seizures, strokes, PIAs, cognitive impairment from, say, dementia or a TBI, spinal cord injury. And then there's some other considerations with regards to, say, like insulin-dependent diabetes, having an insulin pump during a psilocybin session, Addison's disease, liver failure. Medication interactions is the next kind of big potential risk category. That would include taking multiple serotonergic medications, stimulants, anticholinergics, lithium, some other vasoactive medications. And then mental health, we're talking about psychotic disorders, schizophrenia, bipolar disorder, perhaps history of spiritual emergency, substance use disorders, suicidality, personality disorders, dissociative disorders, and family history of those conditions as well.
Ah, that's a fantastically inclusive list. Thank you for that. I'm going to pull apart or ask you to pull apart some of those if you would. I know you started off with cardiovascular conditions. Can you tell the listeners a little bit about why it is important to know about somebody's cardiovascular status before doing something like psilocybin?
Yeah, absolutely. I consider psilocybin like a stimulant. We know that it increases heart rate. That could be 20 to 40 beats a minute for the duration that you're in the medicine, increases blood pressure. Again, can be 20 to 40 points, systolic. So if somebody has underlying, say, unstable angina, or aortic aneurysm, a cerebral aneurysm, we may be putting strain on those compromised organs. And as we'll talk about, there's a spectrum of what that might look like, from heart attack, stroke, death on the severe end of the spectrum, to just getting some chest pain in the middle of a session. And how are we going to handle that? What are the implications for that? What's the safest way to approach that, so that we're prepared for it and not just crossing our fingers and hoping things don't happen?
Yeah, absolutely. And like you alluded to, we'll get to in kind of part B how to mitigate some of those
Hmm.
challenges or those risks. You mentioned insulin dependent diabetes, and that one stuck out to me. Can you
Hmm.
discuss a little bit about what kind of challenges that may lead to in doing something that, one, I think a lot of times they advise maybe not eating right before, and it can be 4 to 6 hours long. So, do you mind covering that a bit?
Yeah, I think there's several aspects of it. One, yeah, you might not be eating for 6 to 8 hours, and so how do you prepare yourself as an insulin-dependent diabetic to be set up for success with that? Now, most insulin-dependent diabetics have managed similar situations where they may have a change in their usual, insulin and eating pattern. But like, here's an example that sticks out of my mind. I worked with a client with insulin-dependent diabetes, with severe depression and suicidality. This client's suicide plan, and had attempts in the past, was to overdose with insulin, with their insulin pump. Okay, so if we imagine a scenario like that, and now being in a deep psychedelic session where your linear and rational decision making may be offline, and we're imagining a scenario where maybe that client is going to be unsupervised, going to the bathroom for a period of time. Sometimes people go to the bathroom and they're in there for quite a while. Maybe they're crying. Maybe they need some time and space by themselves. But you could imagine that, to some degree, not to be too dramatic, but that's like going into isolation with a loaded weapon in a significantly altered state. So um, these are considerations and things that we would talk about in preparation for a psilocybin session.
That is very interesting and a scenario I had not thought about previously. So thank you for sharing that. And moving on to medication interactions, another thing that I think you turned me on to that I had also not heard of, it was either you or Dr. Ben Malcolm, um, is how GLP-1s may interact with psilocybin. So would you mind? I believe you shared that in Denver. Was that you who shared that story?
Yeah, and I think that this is still um, unknown, but we have heard several stories in Oregon since our model went live a couple of years ago, about people who are on GLP-1 agonists who did not stop or skip their doses, who had significantly delayed onset and prolonged episodes. So the first story I heard, um, this was not a client that I saw myself, but heard this from another service center. Client came in, took a dose of psilocybin, standard high dose, maybe 25 milligrams. Hour went by, hour and a half went by, did not feel the medicine, took a booster dose. hours went by, got to that kind of uh, 5 hour mark, and there was no experience. And so the client and the facilitator agreed that this wasn't happening and that they could end their session. Client left the service center, got into, I believe, like an Uber to go um, back to their place, and then started to field the medicine and ended up having a full 6 hour journey outside of a service center. And while there was no harm done to this client, um, this is something that um, you know gives us some pause to clients who are on these medications. So, and again, hearing multiple stories about this, yet not for everybody. So still unknown. There's still some mystery. We're still trying to observe and sort this out. But for now, I am recommending that clients take 3 weeks off of their GLP-1s before a psilocybin session.
Got it. And for those who don't know, GLP-1s are like Ozempic, Mounjaro, Wegovy. And another medication class that you brought up that I would like you to highlight and maybe give us some examples of, and also why it's important to know if somebody's on them, is the serotonergic class.
Yeah, well, there's two reasons why this comes up. One is that being on chronic serotonergics like SSRIs may blunt psychedelic experiences. So part of safety planning is talking about dosing and trying to help people with a dosing strategy that's going to set them up for success. In addition, serotonin toxicity is something that we talk about and try to minimize um, risk. So, there is some evidence now that taking a single serotonergic agent, say taking Lexapro, no other serotonergic medications, no other medications that increase the risk of serotonin toxicity, seems safe. Where I am not at this point recommending that people stop, skip, or taper a single SSRI in preparation for a psilocybin session due to safety. However, if we look at the literature where people have experienced serotonin toxicity with psilocybin, it's generally in context of taking multiple different serotonergic medications from different classes that increase the intrasynaptic serotonin. And so when people are on multiple serotonergics, we generally are recommending tapering until we can get to a single serotonergic agent um, at the time we're doing a psilocybin session.
Great. And can you give an example of some of the non-SSRI serotonergic medications people might be on the lookout for, whether they're taking?
Yeah. So we might be talking about like trazodone, for example, would be one. Tricyclic antidepressants would be another. So other medications like that that can increase serotonin toxicity. Some opioids like tramadol, for example, would be another one that can increase risk of serotonin toxicity in combination with maybe more traditional agents like SSRIs.
Okay, great to know. Now, moving on to what I think is the area we discuss the most, kind of that's basically in the industry just kind of discuss the most overall is what is in a person's mental health, either personal history or family history. And I'm going to get to the family history second, but first off, you brought up some interesting conditions, and I would love if you could elaborate on what spiritual emergency is.
Hmm. Yeah, thanks for bringing that up. Um, spiritual emergency is a term that's used on a spectrum um, from, say, a spiritual awakening. Maybe starting there, somebody who, let's say, does not have a spiritual practice or belief system, who has a psychedelic experience and has a direct experience with something that they're identifying as spiritual, and they would maybe identify that as a spiritual opening or spiritual awakening, and their path to relating with a spiritual practice may be evolving from there. Now, that spiritual experience may be bigger and potentially have more dangerous implications. Let's say that progresses to not just feeling a connection with God, but feeling like you are God. Now, there may be certainly, a gray area in how that single statement is interpreted, and that may not be dangerous at all. That may be part of a spiritual opening and spiritual progression as well. Maybe as we move into further in the spectrum towards spiritual emergency, that may be I am the only God, I am the Savior, into grandiosity and into behaviors, say, uh, invincibility, and veering into what might put somebody in harm's way. And while in one mental health paradigm, that might just be labeled psychosis or mania. And maybe if that person goes to a traditional psychiatric practitioner, maybe somebody who's not particularly psychedelic informed, they may just go straight to a diagnosis of, drug-induced mania or psychosis, and straight to a certain intervention consistent with that paradigm. If that person goes to maybe a spiritual advisor or somebody more experienced in working with clients who are having this kind of big spiritual experience and having difficulty navigating how to work with that experience and be safe in our reality, they may use different language, and they may use different interventions, and they may use um, reassurance and a safe place and a support system, and working within that person's um, understanding of their experience to help them navigate back to a place of stability. So there's overlap, there's different paradigms and practitioners that would be involved in sort of distinguishing terms like psychosis and mania versus spiritual awakening and emergency.
Thank you for that explanation. That is one of those things that, like you said, it's so multi-layered, but definitely, like you said, a thing to look out for if it's happened in the past. Substance use disorder, you brought up. Now, there's quite a spectrum of this as well. So we have somebody who is maybe um, addicted to tobacco. There's, one end of the spectrum who, or maybe they had a previous substance use disorder. So when you bring that up, what are the kinds of things that are, let's say, more in need of a safety plan than others?
Yeah, great question. And we're learning that psychedelics may be helpful for addiction. So this is certainly not to say that having a substance use disorder is a contraindication to participating in a psilocybin session. The specific things that we ask about and assess would be, one, what's this person's risk of presenting to a psilocybin session intoxicated? Okay, so that's something that would be um, discouraged, potentially unsafe, depending on the substance, the degree of intoxication, um, not just physically, psychologically, but also talking about, consent. And we want people to be as clear-headed as possible when entering into a psychedelic session. So that's one facet of this. The other would be what's the likelihood this person um, is able to not show up intoxicated, but is going to be in withdrawal. And withdrawal may include physiologic changes that can act synergistically with psilocybin. So having tachycardia, increased blood pressure, and now adding psilocybin to the mix physiologically could be unsafe. Seizure thresholds decreasing, and psychologically, coming into a session agitated and um, planning on a session where we're not going to be using your substance of choice for the next 6 to 8 hours and taking psilocybin, which is going to cause some degree of altered mental status, right? Like at what point would we be worried about, say, DTs developing versus this is just the result of the psilocybin itself. So those are the two um, scenarios that we're most concerned about with substance use disorders.
Very good to know. Very good. And I'm wondering because, like, as you said, psilocybin has been found to potentially help those who are suffering from substance use disorders. But this is where I'm going to just put a little kind of asterisk because we're talking about psilocybin. But I think a third category may be if you're using something like ketamine that does have more of an abuse potential, might that third category be what is the likelihood that this would end up become misused at some point? Is that a consideration with other, let's say, other medicines? Because we know psilocybin, it just if you just use it too much, it stops working. But I know you also have a ketamine clinic, so I was just wondering if that's a third consideration.
Absolutely. I mean, just to use that example, somebody with a ketamine use disorder um, coming to receive help for that or for something adjacent to that, certainly prescribing oral or other forms of at-home ketamine use would be a very high risk of abuse and misuse. And um, I'm very tuned into that, having had 20 years in the emergency department and practicing and witnessing our opioid epidemic and prescribing practices, you know, over the last several decades. So I think it's a great point that you bring up, and that would be certainly a valid consideration.
And what about you also mentioned somebody who had a history of suicidal, I guess, attempts, I think is what you mentioned. I mean, this is, I think, one of the most difficult things because so many people in who are seeking psilocybin therapy have either come very close to it or have had a significant amount of suicidal ideation. Um, how do you decide when a history of, let's say, attempts or ideation is more, like I said, put you at more risk than others? Like if it's a super remote attempt, is that different from somebody who is perhaps considered it more recently?
Yes, yeah, great question. The way I um, frame assessing suicidal ideation with regards to psilocybin is um, a couple things. One is, having, I'm going to start on sort of the more benign, safer side of the spectrum. Having, occasional or even chronic passive thoughts of, gosh, I wish I could go to sleep and not wake up again, but never having acted on that, never having a plan, um, not having any real desire to harm yourself would be one end of the spectrum. The other end of the spectrum may be somebody who has attempted suicide and maybe is planning suicide and is in a um, relatively hopeless place and um, decides that trying psilocybin, this is it. This is my last hope. And if this doesn't work, that's it. I've got my plan. I'm preparing to harm myself or end my life. And while on one hand, yeah, maybe there is some hope. Maybe psilocybin will be the thing that will help somebody turn the corner. We also know that um, psychedelic experiences can be destabilizing. And that's not necessarily a bad word. If we're prepared for it, we're supported for it, right? Most people are coming into these experiences with the idea of wanting to change their mind, to steal Michael Pollan's phrase. But uh, that comes with a process. That comes with that having that snow globe shaken up and having some destabilization and changing your sense of your identity, your relationships to the people and places and world around you can be destabilizing. And certainly in the days and weeks after a psilocybin session, even for the ones that go great and end up really helping people, it is common to see emotional lability in that period, and to have an unsettled, destabilized, um, sense of your yourself and your reality for a period of time. So, uh, coming into a psilocybin session already in an unstable space and already kind of teetering in a place of self-harm, and then adding this to the mix when we know that this can cause this kind of emotional, lability and destabilization could be potentially harmful. And even just having that notion of, this is my last hope. This is the thing. Whether we're talking about psychedelics or any other intervention, having expectations those that high is certainly, a setup for disappointment. And if we combine that with impulsivity and a plan that's already in place, or access and means, this could be a dangerous situation.
Yeah, thank you for that. And then the last thing I wanted to highlight was you discussed family history. And I would love to hear more about like, are we are we talking first degree relative, like brother, sister, mother, father, or second degree? Like, can you talk about how risk plays out regarding family history?
Yeah, great question. And one of the difficulties with making these decisions or speaking with some confidence or authority on the matter is that the clinical trials that have been done largely exclude people with lots of conditions, family history, and specifically first degree relatives with history of, psychosis and bipolar disorder, are people that don't get included in these trials. So we have, anecdotal evidence, we have population-based surveys to go by. And so when I talk to clients about this, I speak from a place of humility with regards to this. These are not, um, hard and fast numbers that we can quote. We don't have a gold standard out there, but we can work with the unknown to some degree and be conservative right now in this moment and learn as a community as time goes on and adjust our recommendations. So that's sort of the framework that I approach this with. And yeah, so I consider a first degree relative, so parent, sibling with bipolar disorder, schizophrenia, or other psychotic disorders, a risk factor. Now put that in context of the client that we're talking about. Are they 21 years old? They've never had a psychedelic experience before. Maybe they have uh, a parent and a twin sibling that both have schizophrenia. That's going to be a higher risk constellation of factors. But I've also worked with people who are, 67 years old. Yeah, they had a parent who was diagnosed with schizophrenia, but they are 67 years old. Maybe they've had a few psychedelic experiences. I did LSD a couple times when I was in college. I never had a problem with it. So that's lower risk. And that's generally how I talk about this is, what degree of risk, where are we on the spectrum? And what's your risk tolerance, right? Like talked to some people who uh, understand that we're talking about a low risk situation, but they're, say, a primary caretaker for an ill parent or a toddler. And the thought of even having, some extended period of instability, even if we're not talking about a, permanent condition, that's too much. They don't want to take that risk, and that's their choice. There's other people who have a higher risk tolerance for this. So this is generally a shared decision-making process and trying to put the risk that we think we know with your own risk tolerance together to make a decision together.
I love that. I love it. I love it. And I love the humility. And it's a great reminder that while we are trying to give some guidelines here, it is all there are still so many unknowns. And so that is why we are trying to like manage risk instead of saying this is an absolute, like if you go to something like surgery, they may do what's called a surgical clearance. Like, are you okay for surgery? Yes or no? But then, if they find out yes, but they may make some modifications to hopefully make your surgery safer. And I think that is a good segue into what you are very good at and what I heard you speak about in Denver that I really, really wanted to share on this podcast is the ways that you have organized safety planning so that it's not a question of yes or no, is psilocybin safe for me? But how can we make psilocybin if psilocybin is not completely contraindicated, meaning there's, there may be a few people for whom they should never do this medicine. But if you're not one of those and you still have some risk, how can we make it safer for you? And so if we could start by talking about the times when you like I said, when you do need to find alternatives. We're going to talk about some safety planning things, and that's the first category we'll go with is when, psilocybin risk is too high and you need to find some alternatives.
Hmm. Yeah. Yeah, and I appreciate you framing this as safety planning as opposed to gatekeeping, because that's what this process really looks like. And so helping people find alternatives because their risk is too high. I'd say the examples of that would be, well, in Oregon, if you're taking the prescription drug lithium, you're not legally allowed to obtain psilocybin services. Say something like a brain aneurysm or unstable angina, like we talked about before, where the risk of a ruptured aneurysm, the risk of a heart attack is too high, then we may help people find alternative treatments that that may be in the traditional psychiatric system, pharmaceuticals, therapy, TMS, breathwork, as another example. So there's a few but important conditions to address where we really are going to help people find something other than psilocybin to address their situation.
One thing came to mind when you were discussing the suicide risk and how some people think this is like they may be super acutely suicidal, at which point I think it's great that you have both the ketamine and the psilocybin in your toolbox because ketamine's so good for acute suicidality. Can we use another tool like that to get them to a more stable place that then they could try psilocybin?
Absolutely. Yeah. Thank you for saying that. And I appreciate so much having multiple psychedelic options for people. Um, and and ketamine, at least I provided in my clinic, um, also comes with providing it in a medical setting where there's cardiac monitoring, there's rescue medications. I have a crash cart here. I'm generally providing IV infusions where I'm in the room and titrating the infusion in real time with somebody so that we can turn things down if needed. There is more actual control over the experience and the physiology associated with it. So yeah, thank you for saying that.
I love that. I love the options. Yay, Oregon and Colorado. Next category of ways to alter perhaps is to delay the timing. Can you speak a little bit about that?
Yeah. So there's a few examples of this. One just going back to the suicidality part. So having more severe suicidal ideation or planning, may not be the safest time to have a psilocybin experience. That doesn't mean that you can't. And so this may be a matter of staying in dialogue with a client, um, making sure that they have resources and a pathway to get help, to become more stable, to address the crisis that they're in, and then to revisit this when they're not feeling as suicidal, as unstable. And so that may be a flexible period of time. Maybe that's 3 months or 6 months or a year from now. But giving somebody a clear pathway to yes, and what does this look like for me to be safe enough to do this? What does a support system that's going to help me through this look like? And how can I, find and assemble that team and those guidelines? So that would be one example. Another would be, say, medications. Back to the multiple serotonergics. Um, we may come to a place where it does feel safest to taper off of one or more medications in order to have a safe experience. And so that may take, again, 3 months, 6 months, 9 months, and some flexibility in there to respond to what's actually happening. I always emphasize to clients that while we're talking about a specific safety issue like serotonin toxicity, we don't want to trade that for psychological instability and crisis and declare success because we've helped somebody taper off of a medication that seems less safe, and now they aren't sleeping, they're agitated, their depression is worse, their suicidality is worse. So, we have to take a holistic approach to this and consider the totality of what's happening with that client. So again, delaying the timing of a psilocybin experience, having some flexibility, having some guidelines, having a support system in place to do that successfully would be another situation. We talked about the substance use disorder and the risk for presenting in withdrawal or intoxication. So identifying that those are risks for somebody may mean let's delay this until you've gone through a detox and a rehab program and are now in a place where you're unlikely to present intoxicated. Withdrawal period is over, and now we're in a better place to address addiction in a safer way. So yeah, those would be a few examples.
Very nice, very nice. And the third category is contingency planning. Can you discuss what that looks like if somebody is going to undergo a psilocybin ceremony?
Yeah. Well, we're talking about coming to a place where we may have identified a certain risk outcome, but that falls within a client's own comfort zone with risk tolerance. It falls within a facilitator and a service center's risk tolerance. But again, we don't want to just have a let's cross our fingers and hope this doesn't happen. So I'll give you a specific example of a client that I worked with. Thinking of actually a psychologist in her late 40s who had a diagnosis of bipolar 2 disorder. Um, she had been depressed for several months. She was taking one mood stabilizer, had not experienced an episode of hypomania in over 5 years. This psychologist happened to also work with clients with bipolar disorder and was also curious about having a psychedelic experience. They had not previously experienced psilocybin. So they were highly motivated, stable, um, and actually in a depressed state. But we talked about, well, okay, so yeah, this is lower risk. But what happens if you haven't slept for 2 days, 3 days, 4 days after a session, starting to experience racing thoughts, starting to have some grandiosity? What are we going to do then? And the outcome of this was talking to their prescriber, having a prescription of Seroquel in hand at home, and a dialogue already uh, with their prescriber, who happened to be an East Coast, not psychedelic informed prescriber, who, potentially, if approached after the fact without any preparation or warning for all the reasons, lack of the information, education, liability concerns, licensing concerns, may not have been there to engage and help that person, but they had a plan in place. And sure enough, that is how this session played out. They did have insomnia for several days. They did start to have some racing thoughts and recognized what was happening. They had Seroquel at home. They were in contact with their prescriber. They took it for, I think, 5 days, and that was it. It was over. Very grateful for the experience, and so that was an example of a contingency plan that was successful. And I think that this is also an example of how engagement and discussion uh, sets the experience itself up for success. I think that influences the the session, right? Having some dialogue with a support team, some thought process ahead of time about the risks, about what's my safety plan, rather than, again, just, ignoring or escalating the worry, coming into a psilocybin experience feeling as safe and supported, and having your anxiety as low as possible itself is a setup for success. So even if that person, say, never took the Seroquel, I still think that having these discussions, having contingency plans in place is contributing to setting somebody up for success.
Absolutely. And also highlighting again the importance of mainstream clinicians knowing about psychedelics,
Mhm,
because you have to be able to come to them and have them, like you said, it was good that they came beforehand. But still to not have the practitioner at that point go into the just say no mode. This isn't safe. This isn't set, to have the openness to work with you in that setting is
mhm,
really crucial. So thank you for highlighting that. And I love that that plan worked. That's incredible. That was one of the stories you told in Denver that I was like, wow, I can't wait to have Seth on and discussing these things.
mhm,
Um, second to last, you had said improving their support team. Can you talk about that?
mhm. Yeah. So, gosh, I could think of several examples of that. So maybe somebody has a diagnosis of PTSD, has read that psilocybin may be helpful for PTSD, but that particular person has not really done much trauma work, trauma processing, maybe doesn't have a trauma-informed therapist. And for whatever reason, jumping straight to psilocybin feels like the best option for them. Well, we know that while psilocybin can be helpful for that, trauma may come up. But during the session, after the session, there may be a lot of processing. It may be very challenging experience to have. So, connecting somebody with a trauma-informed therapist, or helping them find a facilitator who has a trauma background and can support them, that may include a more extended preparation period, more sessions, and that may end up being part of a timing issue as well. How can we best be prepared for that? That might look different for somebody who has a significant trauma history, who hasn't done much work in preparation on that, versus somebody else. Another example would be, say, somebody with borderline personality. This comes up from time to time. Um, I feel like this is something in that kind of gray zone, moderate risk zone. This may be safe and helpful for some client. This may be problematic for somebody else, but it's something that needs to be addressed. And there are facilitators out there who have experience and expertise in working with people with borderline personality. And again, an extended assessment period, an extended preparation period, having support systems and contingency plans in place are part of setting up a good support system for somebody. It may involve a prescriber, like we talk about with the bipolar 2 client and their psychiatrist, and having a Seroquel or a Abilify type of medication in place in case of a bad outcome. Um, or we talked about spiritual emergency as well. Does this person have a spiritual advisor that would be there to help them? Maybe it's a medical situation. For example, a client who has a paroxysmal atrial fibrillation. This is something that I feel like comes up um, frequently. Somebody kind of wants to know, is it safe? Is it not safe? It's often asked and presented in a more binary way. And again, I don't think that's the best way to approach this. And the best way to approach this is, yeah, what if you go into AFib with a rapid rate in the middle of your session? What are we going to do? What is that going to look like? And so, from a support team perspective, that may be um, are you working with a facilitator who has some medical experience, who can check your pulse and who can tell you if you are in AFib with RVR, or maybe you're, just having palpitations from anxiety or an emotional experience. And as the client, you're in the middle of a psilocybin session and it may be harder for you to tell, is this an emergency or not? And certainly that could escalate. So, who's with you? Where are you? If you do have an episode that does need medical attention, are you in a more rural retreat center where getting medical help, getting an ambulance um, is more difficult? Are you in an urban center where you have an ambulance that's 5 minutes from you? And while we're on the topic, what would that look like if you had to call 911 in the middle of a session? What's the psychological risk of going from a service center into an ambulance, into an emergency department in the middle of a session? Maybe there's something like having a beta blocker with you that you could take in the middle of the session if you did go into a rapid rate that might help at least temporize the situation, get through the peak of your experience, where if you do need an intervention, you're in a psychologically safer place to receive help. So many different components to trying to set somebody up for success rather than the yes, no, black, white approach.
Do you see why I had Seth on? I just love how like thoroughly you've thought through so many of these different conditions. This is great. Well, and to round out our discussion, can you discuss about providing fully informed consent?
Yeah, I think this really kind of picks up where we just were as far as things like what if something goes wrong? What are we going to do? What does a trip to an ER look like? Um, Another example along those same lines would be like somebody with a seizure disorder. We generally consider that a contraindication, but I consider that a relative contraindication. Maybe somebody hasn't had a seizure in 10 years. Um, they're generally lower risk. But what if it happens? What does having a seizure in a session look like? And for me, this actually is, yeah, no, if you have a seizure, we are going to call 911. You are going to go to the hospital, whether you're with a medical person or not. right? Like trying to um, confidently assess a simple versus a complex seizure. Is somebody really returning to their baseline mental status? How do you assess that in a psilocybin session? So that may be something to relay to somebody so that they can really think that part through, not so much coming at it like, what's the likelihood I'm going to have a seizure? Like that's one part of the discussion, and that's an important part of the discussion. But the other is what happens if I do? And that's part of a fully informed consent process as well.
I love it. This type of discussion just shows me how far we've come in the few short years since Oregon has started. And I truly appreciate how much time I'm sure it went into you preparing for all these scenarios and to be able to be there for your patients in that way to provide their alternatives and their fully informed consent and make it possible for people who may have some risk factors, but that you have found a way to mitigate those and help them receive the therapy. Seth, thank you so much. Can you tell us, the listeners, where to find more about you and your work?
Oh, yeah, thank you. Cascade Psychedelic Medicine and Inner So cascadepsychedelicmedicine.com and Innertrek, INNERTREK.org.
Love it. Thank you again. And small ploy, if anybody is interested in taking the course that Dr. Mehr helped us create, go to psychedelicmedicine.association.org and you can find our course there. You no longer have to be a member to take it. We would love you to be a member, but it is now open to everybody and it has information on both Colorado and Oregon's psilocybin model so that if you are a clinician and you just want to learn more about if I say yes to this, what are my patients going to do? How, what kind of safety measures are built into those programs? You can learn all about that there. Again, psychedelicmedicineassociation.org. Seth, thank you again for coming on. Truly appreciate it.
You're welcome. Thank you, Lynn Marie.
All right. For everybody else out there, until next time.